Morning, everyone. If you could find your way to your seats, we're going to go ahead and get started on time this morning. So good morning and welcome to our 7th annual Joy of Medicine Summit. There we go. My name is Eileen Wetzel, and I'm the CEO of the Sierra Sacramento Valley Medical Society, and I really want to welcome everybody here today. It's wonderful to be here in person and to see so many of you. Some of your colleagues are also joining us virtually on Zoom, and we welcome to you as well. So I am thrilled to introduce your MC for today's event. Dr. John Chuck is the chair of the Sierra Sacramento Valley Medical Society's Joy of Medicine Advisory Committee and is the Chief Wellness Officer and Professor of Family Medicine at California North State University. Dr. Chuck is an expert on the subject of physician well-being and also our final speaker for this summit. Please join me in welcoming Dr. John Chuck.
Good morning, everybody. Thank you for, oh, wow, that's good. Thank you for joining us here today. I got here a little early, but I was shocked to see so many of you here, and it kind of reminds me of the good old days in medicine where everybody showed up like an hour early, and so I just love that about you. And I see so many friends out in the audience, and what a great venue, right? Who picked this venue? Big round of applause for you guys. Ronnie? Okay. Where's Ronnie? Ronnie's in the back. Ronnie's relatively new with SSVMS, but she's wonderful, as is the entire staff at the Medical Society. Hey, who's been to the Medical Society offices, at the museum and all that? It's just a wonderful place. If you've never been there, you got to go. And I just want to say right off the bat that SSVMS is absolutely positively the best local medical society in the United States of America. I mean, like, no doubt, no doubt. I mean, I don't know any other medical society that is sort of bringing together the medical community and talking about the issues that are important and actually, getting programs out there that we are engaging with. And they just have a wonderful, can the entire SSVMS staff please stand up if you're not already standing? We got Lindsay and Sam and Ronnie and Eileen and stuff. It's so funny. Eileen is, she's small but mighty. She was back here giving her presentation. I was standing on, and she's on her tiptoes like this and get above the podium and stuff. Anyway, okay. So today's event is part of the overall Joy of Medicine program sponsored by the Medical Society. And the overall purpose of the Joy of Medicine program, number one, it's to help us, physicians and medical students, residents in the community, to engage in self-care. Because as you may recall, if you don't take care of yourself first, how could you possibly take care of these wonderful patients? Ronnie, why are your arms up in the air like that? Oh yeah, I'm easily distracted, okay, so I'm talking to say, it's like squirrel, oh my God, okay, what was I talking about? But I think at the same time, our medical society is very strategic, thinking about, what is the position of physicians in society? What sort of legislation do we need to make it possible for us to do our best work in the world and things like that? So, and actually one of the most recent topics they're tackling is the safety of physicians and patients and the way they're interacting with us and things. And I, as somebody who recently had to have a restraining order done by the courts against a former patient. Yeah, it's a real deal, right? I mean, our work is hard enough. So anyway, thank you, Medical Society, for tackling the issues that are important and producing programs that we actually engage with. Who here has engaged with something wonderful with the Medical Society in their lifetime? If nothing else, you're here today, right? Okay, so wonderful. See? It's working. It's working. Okay. There's so many good things. Okay, so anyway, we actually have a Joy of Medicine Advisory Committee made up of representatives from all the major groups in the community and stuff. And I just wanted to, can we get that full screen, or do we not want it full screen? Or should I just do that? Should I do that? Or is going full screen, could that be super dangerous? Okay. But basically, what you'll see here is that we have representatives from many of the organizations in town, and is anybody here invited to join us for one of our board of advice? Anyway, it's super fun. We sometimes meet, at the Medical Society, and they serve delicious food. And even when it's Zoom, it's super fun. We all get to talk and everything. But the best thing of all about this collaborative committee is that it's not like biotech where people gather for conferences, but they kind of hold on to all their proprietary information. Everybody comes here and they just vomit all the things they're doing in their group, and then we all just steal it from one another. And I just love that whole collaborative nature of this committee. I think that the Joy of Medicine program that the Society gifts us with is just a compilation of all the best practices from all the local wonderful groups here. So give yourselves a big round of applause and please thank your representatives. I also love the fact that we have medical students from UC Davis and North State. Can all the medical students here today please stand up? I know we have at least 2 from North State, okay? These are the people who will be taking care of you when you go to the ER with chest pain or syncope, and so we like you, but we're also fully invested in you selfishly for us, okay? So we want you doing a super good job and enjoying being a physician. Okay, and then of course, the Joy of Medicine program is sponsored by wonderful organizations. I'm just gonna name them all because I like all these organizations. The Physicians Foundation, UC Davis Health, Kaiser Permanente, Sutter Medical Group, Mercy Medical Group, Hill Physicians, Sutter Independent Physicians, Woodland Clinic Medical Group, Placer Nevada County Medical Society, and the Cooperative of American Physicians. Can we have a huge round of applause for all these sponsors? Those sponsorship checks are very much appreciated by the Medical Society, and I hope you think we're using the money well. Yeah, Lindsay, yes. Yeah, keep the checks coming. Okay. Okay, now for some fun stuff. Throughout today's program, we'll be pulling raffle tickets for prizes, okay? So I just want to make you feel happy about that. Is it time to pull a raffle ticket yet, or is it way too early? They haven't earned a prize yet? Okay, let's make them sweat a little bit, okay? And then also, you may have noticed, and I see that some of you have already engaged, we have professional massage therapists here for your pleasure up until 11:30, okay? So, and I see we have at least one in the room here. I know we had some outside. Maybe during the lecture, we can bring them all in here. And feel free during any of the presentations to just get up and go get a massage because you won't want to go home and say, oh, I wish I had a massage. Okay. All right. Turns out that today's 3-hour-long presentations are all eligible for CME credits. So if you're here in person, there's going to be a paper evaluation that you fill out. If you are joining us remotely, and let's have a warm round of applause for all our remote participants today. All of you sitting at home in your pajamas, drinking hot chocolate, you're missing out on a super good frittata here at 1601 Alhambra. I didn't even know this facility was here. I barely knew Alhambra Boulevard existed, but here it is, and it's really nice. I was thinking about renewing my wedding vows here in a ceremony, and you're all invited, okay? We'll be gathering at 12:30 p.m. today, and we'll just be having the leftovers from what you're eating right now. Gifts are not required, but we are registered at Target. Okay. Which, by the way, sells wonderful men's clothes. You think it's just for, like, dish racks and drinking glasses. They actually sell clothes also. Okay. Okay, so, right. So, and the remote people, you claim your credit using a link that is in the chat function. There's also going to be a QR code in one of the slides that you can scan later for that. Okay. Okay, now for something super nice, we're going to have Drs. Giroux and Hudnut come up and share some poetry with us. Can I big round of applause for them as they come up to the front?
Good morning, everyone. It's a pleasure to be here. And I'm going to read the poem called Healing Equinox. Illnesses, fragments, imbalances, blocked solstices. The doctor is a giant stethoscope to the human soul, silently examining, realigning energies or chakras, planets. with fluids, pills, surgeries, words. The doctor holds birth and death like two parentheses containing human condition, suffering, but also miracles, such as joy, gratitude, service, compassion, hope. Breathe in, then push as life comes out of one's belly. Breathe out and let go as warmth leaves the body. Medicine honors both day and night, night and day, loss and resilience. Heartbeats of the wind, breathe in, breathe out, self-anchoring. The in-breath of the summer morning, the out-breath of the winter evening. But before darkness, a fall, fatal or not, it forces a pause. After climbing a hill, before hiking down, between intention and leap, so standing at the peak, time to harvest all of life's teachings year to date and bring to light deep wisdom from tangible world lessons. Medicine also teaches as a stepping stone towards evolution of consciousness and integration of polarities, or equilibrium between yin and yang, decline and growth, youth and aging, the divine feminine and the sacred masculine. Doctoring makes the human soul an equinox of all moments.
So a couple plugs before I read a poem. Carolyn and I and several others in the room are part of the Med Poets Society, which is here at SVMS. So please, anybody who's a creative writer, anybody who would love to write poetry, Sam is our wonderful support. Reach out to her, and we get together about every 3 months, and we meet at coffee houses and people's houses, and we write poetry, and we share poetry, and we edit each other's poetry. So that's where this is all coming from, Med Poets Society. So this is entitled Atlas Smiles. Atlas bends under the weight, in basket, chart closure, panel growth, access, supply-demand mismatch, productivity, leadership challenges, cross-covering, call. A bead of sweat navigates the brow ridge. A knee bends closer to the ground. A shoulder gives to the gravitational weight held above. Until a perspective shifts, a breath is found, an eye sparkle returns. This patient needs care. Accurate diagnoses are found. Effective treatments are offered. Teamwork is built. Addictions are lessened. Cancer is found early. Procedures help cure. Mortality is accepted when all other goodness has been applied. Within this experience, the weight is still present and yet shifted from a globe pushing down to a backpack carried. Creases reach outward from the corners of the mouth and the edges of the eyes, emerging in awareness and strength. Atlas smiles. Thank you so much.
That was just wonderful. I mean, are you also good clinicians? And like, if you can also play tennis, I'll just be super jealous. But anyway, that was really, really good. Thank you very much. Okay. I think we're ready to get moving with our speakers. How does that sound? Sam, am I doing everything right? I always just look to Sam and the staff like, am I doing okay? Okay. I'm really happy to introduce the first of our three speakers today. Dr. Andrew Smith was an assistant clinical professor of family and community medicine at the San Joaquin General Hospital Family Medicine Program. And he recently transitioned over into a private practice in psychotherapy and coaching and consulting, and works primarily with physicians. So can we please give it up for Dr. Smith? Come on up.
It won't let you advance on the big slides where you hit the little ones.
Hi, everybody. Everyone should have poets before their talk. That was what a great lead-in. So I just want to say thank you for having me. I also just want to say I love the title of this talk, this conference, I should say, The Joy of Medicine, because everybody has, I'm sure, connected to that joy. And I think it is in the connection with people. And when we think about joy in general, it's often related to some human connection in some way, love, just heart connection, friendship. And so that's one of the things that medicine gives, is that opportunity to connect with people and feel that connection and be part of their healing, or at least bearing witness to their suffering in a way that feels very meaningful. And I don't have to tell you this because you're all living it. There are so many barriers that are put in the way of that joy, from electronic medical records to insurance billing issues to time management issues. And then we have when our patient connection gets disrupted. And I think that the first two talks today are really about that. From patients denigrating us to actively attacking us, and what a betrayal that can feel like. But I think it's really important to remember that joy is not something to attain. It's something that we need to remove the barriers to. It's already inherently there. And so that if you can stay connected to that, that's super important. So I love this conference and that you guys are here, and I'm really glad to be here. And I was asked to talk on this topic, and I just found out this morning from Lindsay, and it was super helpful because I'm going to talk about some stats. I was really having a hard time. I think, stats take time to catch up. And with the pandemic, it's just not caught up yet. It'll be maybe a year from now where we can really look at how the pandemic impacted things. But the stats of the membership survey, is Lindsay in the room? It was at least, that's okay, it was at least 30%, which is higher than the stats nationwide from before the pandemic. So it really does demonstrate, I think, that it has gotten worse, and that's probably what your lived experience is, and that's part of why you wanted to have a talk on this topic. So I'm glad to be here. So disclosure statement, no disclosures, no financial conflicts of interest. So it's a big topic, not a lot of time. We can't talk about everything. We're not going to talk about active shooting scenarios. I did leave some room I left some materials at the end of my talk that you can reference if you want to look at more information on that. Also not designing an emergency operation plan. I also found out that the Medical Society is doing something around protocols for this, and that's fantastic. That's great. So you can access some of that from what the society is doing, and it's also just very important that you have that in your institution. So what will we be talking about today? A little bit on the problem of violence in medicine, which you already all know about. What are the risk factors that are important to identify so that we can, what can we do about them? And then, most importantly, the bulk of the talk will be strategies for prevention and de-escalation. And then at the end, we're going to have a little time to practice a little bit what you've learned on a patient case scenario. So again, I think we can look at these stats, and one of the things that we notice with these is that the bulk of the workplace assaults are going to be in healthcare. And that when we think about violence, it's not always physical. Social media harassment, death threats, that's unacceptable. Sexual harassment, unacceptable. And really, it's how it's perceived. Early on, when I started at the hospital I was working at, a patient threw a wadded up dirty Kleenex in my face. Obviously, it wasn't physically hurtful, but it impacted me. It shook me. And so those types of things can happen, and they impact us. So we're going to talk a little bit about some of the risk factors, and I want to, you doing okay?
So this is the slide that you're on.
Oh, okay. Got it. Okay, sorry about that. Thank you. I'm looking at the wrong ones. So I want to kind of paint a scenario. First of all, think about, when does the patient encounter start? If you said when you enter the room, I'm going to say you're wrong. The patient encounter, I would say, starts when the patient is preparing to leave their place of residence to come to you. So what's going on for them at that moment? They've got a health issue that they want to talk to you about. They're anxious about their health issue in some way. They've got to prepare for that visit. They've got to take time off to get that visit. They've got to transport themselves there. Maybe they hit a bunch of red lights, or maybe they have to take 3 or 4 buses to get there. Maybe they don't have childcare, so they got to bring their kids with them, and their kids are, fussing, and they got to focus on them while trying to get to the medical visit, right? And then they get to the waiting room, which might be crowded, it might be hot, it might be just an unpleasant place, and they're already stressed out. So now they got to sit and wait in the waiting room. Maybe when they get to talking to the registration staff, the registration staff is a little bit cold to them. They're not, there's an issue with their insurance or something, and so it's just extra stressors that start to come up. And then there's the wait. Wait times have gone up. Patients, when they're made to wait and they don't know why they're waiting, it's stressful. And I think about that inner sanctum. So you get from the registration, you get vitalized, then you get in the room, and you're waiting for the physician. This is the magical moment that you've been waiting for. And you never know how long it's going to be. It could be a minute, it could be sometimes an hour. And you're just sitting in this room with that energy that is anxiety-provoking. So I think it's really important that we remember, what is the patient experience all the way up to when we see them? Because we can't always know. But we can, I think if you surmise that they're already going to be under some level of stress, it's important to think about, because violence doesn't happen out of the blue, which is hopefully one of the things you'll get from today. I think it's also, one of the things is, I'm going to just make a plug here. If you have on-site mental health support, it's so helpful to be able to do a warm handoff for a patient who's stressed, agitated, or having a psychiatric, if they have an underlying psychiatric condition, stress is going to exacerbate it in that moment. And you don't have a lot of time sometimes to help them. But if you've got that mental health professional that you can either warm handoff or you can consult with, what do I do for this patient? It's super helpful. Patient factors, and I like to put biopsychosocial because I hope I'm preaching to the choir here, but patient health issues are at the very minimum a combination of all 3 of these things, and then maybe some more things on top of that. But patients obviously with active intoxication, withdrawal, any type of substance issues, that's disinhibition, and that's going to be making it a lot more unpredictable about how they're going to be with you. I'm sure you've experienced that. psychosocial stressors that patient may be undergoing, such as job loss or divorce or just things like that that we may not know about that are impacting them, that's adding to their stress. Being in pain. Whenever you hear the word "you doctors," you know that they're coming in with a bit of a chip on their shoulder from previous negative experiences, and you're the stand-in for all of those negative experiences. So they're not seeing you for you. They're experiencing you as they're already expecting you that you're not going to be there for them. So that's a sign that you don't have a treatment alliance when they say that. And of course, psychiatric illness, either an acute or chronic. Acute tends to show up more in like the ED, but you can see that sometimes in the primary care setting. Physician factors. Of course, many physicians these days overwork, stressed, and we're going to talk a little bit more about burnout in a moment here. What you're bringing to the room, your own stress, your own anxiety, your own countertransference, right? We have to acknowledge that we have feelings about our patients that aren't always pleasant. If you're overly assertive with certain patients, that can activate them to be kind of like a battle with you, like that. And younger male, sorry the younger males in the room, but you're at higher risk for receiving violence. And also younger males are at higher risk for giving violence. So testosterone, I don't know what it is, but. And then we have societal factors, right? The social determinants of health. So all of the social ills that we think about, all the stressors, the intersectionality of the stresses and the isms, all of that kind of combines, it's all in the room. Even when you can't see it, it's in the room, impacting you, impacting the patient. For example, the pandemic has been just a big, big thing that we still don't fully understand how it's impacted all of us. So those are some of the risk factors. Now, I understand most of you are in primary care, but do we have any emergency room people here? One or two? Great, okay. Any psychiatry people here? Any people who do geriatrics? Okay, so unfortunately, whoops, you guys are at the highest risk, and you probably already know that. And a lot of the literature is based on ED. But I think, I'm adapting all of this as well to primary care. So how does all this impact you guys? Burnout, all-time high, 66%. That is unacceptable. And I think that is a pandemic-related statistic, and hopefully it does get better. Stress, depression, anxiety. Now, when we talk about burnout, maybe you've all heard of the Maslow burnout inventory. There's 3 domains that they look at, and the one that mostly concerns me of these 3 is depersonalization. That means that you stop seeing your patients as people. You lose your compassion for them, and that is just so tragic when that happens, because that just worsens your burnout when you start to other people and not have that connection that's so important. But more importantly to our topic today, when you're not connecting them as people, they feel that. They feel that, and that can set them off to start to be upset with you because they're so vulnerable, right? They need so much from you. And remember, so much of violence starts with vulnerability. So you're like, okay, that's good. Thanks, Dr. Smith. But what do we know when our patient's likely to be violent? Like, how do I know which patient? I'll have all that context, but right now, what do I do? So one of the things that I like, there's a bunch of different scales out there, but this is one I like in particular. It's called the Behavioral Activity Rating Scale. So it starts with the first 3, which are, not anything to worry about. Number 4, quiet and awake. Hopefully that's where most of you are. I think probably a few are at number 3 there. That's okay, you're physicians, I get it. When you get to 5, 6, and 7 there, that's when you got to start having concerns about where your patient's at. That's when you have to take a pause on what you're doing with that patient. And now that's when you need to start addressing what's going on for them. So in terms of scoring, any score higher than a 4 should trigger that urgent evaluation. Again, those are your what you need to look at. is when they're starting to get overtly active, but they're still calmable, right? That's when you want to intervene, is at that 5. You can still intervene at 6. 7, obviously pretty hard. And if you can have any information about their behavior prior to getting there, remember how I was explaining all of that context from before? If you have some kind of information, maybe the registration person or the MA will tell me, gosh, this guy's really agitated. And that's useful for me walking in the room to know what that information is going to help me to decide how I'm going to start that encounter, right? And as I said before, agitation is almost always connected to some kind of underlying vulnerable emotion that the patient is having a hard time expressing. Now, I'll ask a question of the men in the room. What's the one emotion that we're allowed to express without being considered weak or vulnerable, or weak or woman-like, so to speak, from patriarchal standpoint? What's the one emotion that we're allowed to express? Anger, and the women know that too. So angry men, right, more than we do probably, angry men have some kind of an underlying thing going on for them. And it's important to remember that, is that they can't express their vulnerability in any other way, and they don't feel safe to. So in those that I gotta get out of here, the kind of perseveration, that's a sign that they're really getting into that agitation. And there's a continuum to it. Now, the medical setting is an anxiety-provoking setting, just from the fact that you've got something wrong with you, so to speak, unless it's a preventative visit, which still you're hoping they're not going to find something wrong. So it starts with anxiety, and it progresses from there, from high anxiety to agitation to aggression. So when your patient's anxious, that's a good place to start, is to try to figure out how to help them to calm down. So what can you do? This is the most important part, right? What can you do to prevent and de-escalate? So I think that it's important that what you have control over in terms of the physical space that you're in, the amenities that you have in the offices that you're using actually can make a real difference. There's some interesting information, research about green spaces. Maybe some of you have seen this or heard of this, but the more green spaces that are there, the less likely there's going to be to violence. There was this interesting study where it was some inner city housing project, and there were these trees right outside of the project that were very full and thick, and the police didn't like those trees there because people could hide, criminals could hide there, they could stash their weapons there, and they were like, we got to get rid of these. So they chopped down those trees, and there was no green space at all around the housing project, and violence went way up. So there's something mitigating about green spaces. So plants, and this is interesting, it can even be a picture of green space, like a painting or a poster of some kind that shows green space can have a calming effect on your patient. And you too, right? That's a nice thing too. Think about windows versus a windowless fluorescent light situation. Those are going to also have impacts on what the patient's feeling. And I know we don't always have control over that. But what you do have control over is how you start that encounter. So walking in, sitting down as soon as you can, inviting the patient to sit down. And I don't like the patient on the exam table. Sometimes they'll start there, right? But their feet might be dangling. It's a vulnerable position, and you're not most likely you're not going to start with a physical exam. So I think it's nice to invite them to step off the table and sit down in the chair, and now you're eye to eye, and you're not above them, you're not standing over them, which is kind of an intimidating thing, right? So you get eye level, sitting down. It also conveys, I've got time for you. Even if you feel like you don't, it conveys, we've got time, we're going to have a conversation. So you're already starting a connection with them. Always start with an open-ended question. Well, before I get to that, greeting the patient with some small talk I think is really nice, especially if you've never met them before. Or even if you have, how are your kids doing? Something that's a human connection beyond just what's wrong with you or let's look at your labs. Starting with a human connection. I know you're short on time, but believe me, this is worth its weight in gold. When you just start a little bit with that, it's going to potentially help that patient to see you for you and not just this white-coated physician who, whatever they're projecting onto that, if that makes sense. And maybe you've heard this research that if you give the patient the first 90 seconds to talk, they don't feel rushed. They don't feel like even if you're in a hurry, they don't feel like you're in a hurry. Because think about it, patients they're thinking about what do they want to tell you. And you may think that their priority is not what they need to talk about. We need to talk about your chest pain, not your hangnail. But to them, that's their priority. Give them the first 90 seconds, then they get it off their chest, and it kind of settles them. And you get a lot of information from that 90 seconds. So it's not wasted time, because most of your diagnosis is from the patient, what they're telling you. So remembering to start and giving them that 90 seconds can do a lot to de-escalate them from the get-go. And of course, reflecting back and summarizing what they're telling you shows that you're tracking them and understanding them, and they feel that connection. So you can establish that alliance and that connection from the get-go, and then it's much less likely that you're going to end up in a situation where they're going to be abusive in some way. Now, who here practices motivational interviewing? Okay, who here has studied motivational interviewing? Okay, so it sounds like it's a good thing that we're talking about this, and good for you, those people who are doing it. I highly, highly encourage you to learn more about this. This is what I call your plan B. Every physician needs a plan B when you've lost your treatment alliance, when you and your patient aren't vibing anymore. So the traditional patient-physician style is that the physician is directive. The physician tells the patient, this is what's wrong, and this is what I want you to do. I want you to take this medicine. I want you to go to physical therapy, change your diet, get this procedure. And most of the time the patient says, thank you, that's exactly what I wanted, I appreciate that. But as you all know, there's patients who, they might say thank you and then they don't do it, or they're resistant to you for whatever reason. One that I still find kind of funny in a way is a patient told me I wasn't very green friendly because I was telling him his marijuana was a problem. So, and he had these internet websites that showed how good it was for you, right? So that's tricky, right? And maybe Dr. Morrison, you're going to talk about that social media thing, right? That can interfere with our doctor-patient, how they see us and perceive us. But so when we've lost that treatment alliance, and you know it, you just feel it when you've lost that treatment alliance, we can rephrase that resistance. And from the motivational interviewing philosophy, resistance is a sign to alter your approach. If you are saying, well, this patient's resistant or they're lazy, they're just not doing what they're supposed to be doing, that's a sign that you're kind of othering them and not really looking at the context for what's going on for them. It's easy to blame the patient. And when you start blaming the patient in your mind, that is going to increase the risk for some kind of escalation between you and the patient. When you start feeling yourself being defensive, escalation. So we need to see this as it's time for my plan B. I need to do something different than just keep telling them the same thing over and over about what they need to do, because they're not going to do that the more I tell them. So how do you deal with resistance? In the MI world, it's called rolling with resistance. So how you do that is by reflecting back what they're telling you. When they're telling you something that is not in a productive direction, we reflect it back to them. So I'm sorry, I want to hit one step ahead. I'm sorry. And the Tai Chi approach. Does anyone here practice Tai Chi? Okay. So Tai Chi is this approach where you take I know it looks like it is good for your health and well-being, but it's a martial art. And the idea behind it is different than traditional martial arts where you're blocking and counterpunching. It's more you taking your opponent's energy and redirecting it. And so that's what motivational interviewing is doing, is it's redirecting that negative energy in a way to something more productive. So reflections. There's 4 different types of reflections that we're going to talk about. The first is simple reflection, then rephrasing, paraphrasing with inference of intent, and paraphrasing with inference of feeling. Has anybody seen this patient before? Yeah, right? The bane of the physician's existence. That's something you enjoy. So, what do we do with this patient? Let's start with simple reflection. So remember, he's saying, let's go back for a second. I just need my pain pills and I've been waiting for hours. You need your pain pills and you've been waiting for hours. So what you're doing there is you're demonstrating that you're hearing them. They're wanting to battle you. If you start in with, I can't give you your pills, they're not the right pills for you, you're not meeting them with what they need right now, which is they need to be heard and understood by you. I have a little bit of a funny story about this particular simple reflection, which I was doing a workshop with some medical students and residents, and one of the residents said, but Dr. Smith, if you just reflect back to them, they're going to know exactly what you're doing. It's like you're parroting them. And I said, so you think if you reflect back to them, it's going to be like you do exactly what they're doing? And she said, exactly. So it works. Now, if you have not done motivational interviewing, stay with reflecting. You could do this for like a year. Just keep doing it until it becomes like second nature to you. The simple reflection, it's worth its weight in gold. It de-escalates just that, okay? If you get bored with the simple reflection, you can start rephrasing it. You've had to wait hours to try to get your pain medication, what might be a rephrasing. You're saying the same thing in different words, or different order, right? And if you want to start getting more sophisticated, we go into paraphrasing with inference of intent, which really starting to demonstrate your understanding of what they're trying to tell you, the meaning behind it. So a couple examples. You didn't think you'd have to wait this long to see me and get some help. It's hard to have waited this long, especially when you're in pain. You see how that kind of demonstrates that kind of compassionate understanding? But the holy grail of compassion is when you infer their feeling, that vulnerable feeling underneath. That's when you really got them. But be sure you're pretty solid on what that vulnerable feeling is. Or you can just say, I'm taking a guess here that maybe what you're feeling really frustrated and scared because you've been waiting so long and you're in some pain. And again, even if you're wrong, if you're trying to understand those feelings, it's reconnecting you to them. When they're ready to battle you, you're not taking that bait. You're dropping the tug-of-war rope and you're trying to connect to them. I see that you want to battle, and something's going on for you. Let's stop what we're trying to do here and figure that out. Does that make sense? So I hope that I've successfully planted a seed that if you've done motivational interviewing, to do more of it. If you haven't done it, I added some resources at the end of the talk for how you can find more information on how to get that. All right, so let's get to some specifics on de-escalation. There is no gold standard consensus, but there are some agreed upon techniques. So there's from one of the articles I was looking at, there's 10 domains of a meta-analysis that can be effective. And we're going to go through each of these. How are we doing on time? Okay, so you see the first 5. I'm going to go through each of these, so I'm not going to read each of these right now. Okay, let's start with the first one, respecting personal space. So maintaining at least 2 arm lengths, and this comes from the ED world, but I think it can be effective, if possible, in a small room. If the patient's getting agitated, keep some physical space from them. Now, is there anybody, and move away from them if they tell you to get out of the way, immediately move away. I want to talk about trauma-informed care real quick here. I think we should all be practicing from this approach. And medical students, are you guys being trained in this? I see one of you over there. I don't know where the other ones went. Are you getting trained at North State in trauma-informed care yet? Okay, you need to talk to your faculty. Faculty. Okay, trauma-informed care is super important. Trauma is on a spectrum, right? And everyone's been through what we call a small t trauma with the pandemic. All of us. So trauma impacts the person. Now, we don't know what that patient's trauma is. It could be something from their childhood, sexual abuse. It could be, but one of the things that we see in medical trauma is a huge problem, right? And something we might not always remember, and I've had many, many patients, the medical setting itself is a traumatizing, it's a trauma trigger for people. They might have brought their family member to the ER or that hospital and they died there. And so I've had patients who can't come because it triggers their trauma to come to the medical setting. And what happens what do they call the sympathetic nervous system that's triggered? What do they call that? What's the colloquial term? fight or flight. So if that patient is activated and agitated, they're either going to flee or they're going to fight, and fight is violence. So recognizing that that patient may be in a trauma response is super important as to why they're behaving this way. So hopefully that's pretty clear. Is anybody here ex-law enforcement or military, or has worked with law enforcement and military? So, okay, just a couple of you. I'm going to put you on the spot here. Why don't you block the doorway? It's the patient who has that military history, law enforcement history. They always need an escape route. Every time they go into a room, they're casing out, where's my escape route? I cannot be blocked in. So, and this probably goes beyond military. Anybody who's been in a situation where they didn't have control is probably needing a sense of control. So if you perceive that that patient, or you know that patient has a trauma history, don't block the doorway. That's gonna escalate. If they can't flee, they're gonna fight. Number 2 domain, do not be provocative. And, so that basically means a couple of things. One is, don't say something humiliating, like, you're acting like a baby right now. Nothing like that. Your body language should not be closed. It should be more open when you're talking to them. And, a lot of times when a patient's escalating, it's not just you. And in a medical setting, there's multiple points of contact. So you might be there with an MA or a nurse or someone else that's with you. And if that provider is being provocative in some way, if they haven't had that de-escalation training, you have to check them. You have to make sure maybe they leave the room, but they can undermine the good work that you're trying to do to de-escalate that patient, right? Everybody in that whole system needs to be trained in de-escalation. So good for you for being here. Take it back to your institution, wherever you work. Everybody, from the registration to MA to the nurses, everybody needs to be on the de-escalation training, ideally. Domain 3, establish verbal contact. So ideally, you have only one person verbally interacting with the patient. That gives you that control. Maybe that's going to be you. If you're the first person to contact them, yes. If you're not the first person, but the only one who's been trained in de-escalation, you take over. So only one person is engaging with them. It's going to be much less overwhelming for them if multiple people are trying to talk to them. So how do you verbally engage? Hi, I'm Dr. Smith. I see that you're struggling, but by the way, how do you prefer to be called? Oh, Mr. Jones. Thank you, Mr. Jones, for letting me know. I'm here to keep you safe, and I'm here to make sure other people are safe. If you think that they're delusional in some way, that or like people who are traumatized might be in a flashback, and they might feel like they're reliving where they are or were. And so if you feel like they're not oriented to where they are right now, then you can orient them. You're here in this medical office. And I'm here to help you. I can't do that until I know that you're safe and that I'm safe. So you're saying it in a very polite way, in a matter-of-fact way, in a gentle way. So use short sentences and simple vocabulary. If they're flooded, they're not going to take in a lot of information. It's going to overwhelm them, and it's probably going to trigger them even more. So keep it short and keep it simple, what you say to them. And get in little small chunks, giving them time to process what you're saying and respond before you give them additional information. You want to see that it's sinking in. And if you need to get that information out, repeat it as often as you need to until the patient's processed it and heard it. Don't worry about time in that. Just your goal is to get them to where you're having a connection and engagement. When they're flooded, they're not hearing you and they're not seeing you. But when you can actually connect with them again, then you're well on your way to the de-escalation. Domain number 5, identify wants and feelings. So there's something, like I said, there's some kind of vulnerability behind that escalation. So what was it? What were you expecting when you came here? What are you not getting that you thought you were going to get? And maybe it's disability paperwork, or it's pain medication, or some common ones, right? And if you don't feel like you're in a position to do that, you can tell them, look, I'm not sure I can provide that for you, but I really want to know so I can see what can be done about that. Right? You don't want to promise something you can't deliver as just to de-escalate. Right? That's not good medicine. And if you know the patient, you know why they're there and what they've historically had trouble with, you can use that, and that can save you some time. Like, I know that historically you've wanted oxycodone, and that this has been really hard for you. So is that part of what's going on for you today? Listen closely to what the patient is saying. This goes back to the whole ethos of motivational interviewing, right? And active listening. De-escalation is we might call it more passive than active. It's getting them to talk about what's going on so that they don't have to. What if children act out? I know we have parents in the room. Children act out because they don't have the language to explain what's going on for them. So when you don't have your language for the faculties, you're going to act. Acting out doesn't stop from childhood, right? We'll act out with our partners, the silent treatment, things like that. Those are acting out behaviors when we don't feel like we can talk about what's going on. So re-engaging them on what they can talk about, what's going on, then they're not going to act. They're much less likely to act it out. Agree or agree to disagree. So the motivation interviewing strategy here, the term would be coming alongside them. So when they're wanting to kind of, have this, they're here and you're here, and you doctors, and you're not giving what I want. When you can agree with them, it's like you come alongside them and you're looking the same direction. You're saying, yeah, it is really hard to wait a long time. Yeah, it is hard to not get what you want. And so they begin to see you as an ally instead of an adversary. And if they're delusional, you don't have to agree with the delusion. Just, gosh, that would be really hard. If I were feeling that way, if I were feeling like everyone was out to get me, I would be really scared and freaked out too. I get it why you feel that way. So you can agree with the feeling, not the delusion. Going back to our pain example, this is for agree to disagree, because hopefully you're not just giving out oxy like candy, right? I understand that you feel oxycodone is the only medication to help you with your pain. I too want you to be in less pain. I have other options in mind for you that are safer for you. We'll have to agree to disagree on oxycodone. So it's letting them down gently. If they're at a place where they can hear that, but you got to make sure they're ready for that, right? So this isn't the first thing you say necessarily, depending on if they're actually actively listening at that point. So you don't just have to take it all. There are limits that you need to set with the patient, but you have to set them in a clear and matter-of-fact tone. And this is something to remember, is that when someone is engaging you with a lot of heat, it's going to activate your trauma response, mini trauma response. I feel in danger. My heart rate is up. And there's interesting research. There were these two couples therapy researchers, the Gottmans. They were a married couple and very famous. And they did this research at University of Washington where they hooked up these couples to electrodes. And they found that if either member of the couple's pulse rate was over 100, they could not have a productive conversation. And you doctors like your vitals, right? And so I think when your patients, you could probably look at your patient and say, yep, their pulse rate's over 100. Or my pulse rate's over 100, right? And so you're not going to have a productive conversation until things start to settle down. And so if your voice is raised, if your body posture is set and combative stance, that's going to activate them more. So if you're setting a limit, you have to set it in a neutral, matter-of-fact tone. You are yelling and upsetting the other patients. I would like it for you to speak without yelling. Some more examples. Your behavior right now is frightening, and I can't help you if I don't feel safe with you. I want to help you regain control and behave in a safer manner. I really can't hear you when you're pacing and I don't feel safe. I want you to sit down and calmly tell me your concerns so I can help you. Ninth domain, offer choices and optimism. So alternatives to violence. Do you want to call your spouse maybe? Do you maybe write down what's going on? Just give them some choices. Do you want to punch this pillow? Or just something that gives them a choice other than violence. Offer things that can be perceived as an act of kindness, like some food or drink, a phone call, just things where, what do you need right now? You thirsty? So you're just kind of nurturing a little bit, maybe, if that makes sense. And then offering some optimism. You're going to regain control soon, and you're going to be safe, and we're going to get the help that you need. And the final domain is debriefing afterward with the patient and the staff. So after things have settled down, maybe that visit or maybe the next visit, you want to help that patient to problem solve why they came in, and also why they came in with such heat. Because if they do that again, you can explain to them they're probably going to get discharged from the clinic. Like they came this close, and they don't want that, and you don't want that. So you can't just pretend like it didn't happen. You want to debrief it with them. It's also a way to reestablish that treatment alliance. If you don't have a treatment alliance, you're dead in the water. And it gets broken from time to time. And when that happens, your number one goal is to reestablish it before anything else occurs. You're not going to move forward with that patient until you reestablish that treatment alliance. And of course, you also want to debrief any staff that were involved in that situation. And the involvement, again, could not be right there with the patient when they're agitated, but it could have been the staff that started to escalate that patient inadvertently and unknowingly. That's useful information to them to know that. But ideally, you guys get trained as a team in how do you all work together? What are each of your roles? And you talk about, well, how do we do with that? What went well? What didn't go well? And then it's important to be able to debrief and process those feelings. This is one of the things that I find really striking about working with physicians is there's so much heaviness, depending on your day, really heavy stuff, life and death stuff that you're seeing and dealing with, and just that patient energy that you're taking in can be a lot. And the culture of medicine is we don't talk about it. That's why I love the poetry and the societies where you can be real with each other. It's so important, so important. But when something heavy happens, it's important to talk about that. It helps you to discharge it. That was scary. That was hard. I got really pissed off at that person. I lost my compassion for them in that moment. When you say it out loud to someone else, the response you're going to get is, yeah, I've been there. I totally get it. That happens. So you're kind of expressing your feelings so you don't act them out on the next patient or on yourself or on your family. It's so important that you identify your own feelings, acknowledge them, and express them to a trusted other. So hopefully you have colleagues or a therapist or a coach or somebody that you can talk to that helps you to discharge those feelings. And as the physician, you're seen as the leader in that system. So your MA needs to talk to you, or your nurse, or some other staff person might need you to help them to understand what's going on for them. Okay? So the good news is this doesn't have to take all the time in the world. Most de-escalations can be achieved within 5 minutes. Okay, so let's summarize for a minute. So you're looking for the signs of increased agitation, that raised voice, the swearing, the body language, right? Always being attuned to that. Like there's in every communication, there's content and process. You've got all the medical content that you're trying to get through with that patient, but what's the process of how that's going? What's their body language? What's their tone? You're reading all of that all the time. And when it's fine, you're not even really thinking about it. But when it's not fine, and it's time to stop the first part, catch it, and start to figure out what you can do to get that back under control, where you can restore the treatment alliance and de-escalate the patient. You're monitoring your own tone and body language. How are you getting activated? How are you coming across to that patient to help them to become de-escalated? If you have to leave the room, this is a de-escalation technique as well. Make an excuse to have to go check something on the computer. Sometimes when there's not an audience to engage, then they calm down. And I've actually used this a number of times where they start to ramp up, and I say, let me go check on something for you about this, okay? I know you really have a concern about this. Give me a second, I'm gonna go check on something. And I just leave the room. I calm myself down, and I come back after a few minutes, and I can go do something like, some paperwork or something so it's not wasted time. Then I come back, and very often they'll say, Dr. Smith, I'm sorry. I got a little out of control. I'm sorry. Because when they don't have the object to engage, they can start to catch themselves a little bit. And again, catching it on the earlier side is always ideal. Engaging in that reflective listening until you see the de-escalation occurring, and setting the limits on the behavior after the patient's calm. That is not acceptable for you to yell. It's not acceptable for you to be threatening. You may not be able to come back if you do that. Okay, now, this is going to be fun. Everybody has a handout that is in there in your, and online, I think you're going to post that, or is a link to that in the chat, I hope. Go ahead and open that up. This is going to be your cheat sheet. This is where you're going to, we're going to have a patient scenario. And we're a little test here to see what you took in and what you see in this patient encounter. So you can check. There's a lot that didn't go well, and there's some things that did go well. So notice what didn't go well, and if you're being generous, try to find some things that did go well for this encounter.
Hello, Ms. Jenkins. My name is Dr. Barbieri.
Oh, good.
I was called here because I was told that you are in pain.
Yeah.
I can help you with that.
My stomach just, oh man, it hurts. And
Yeah? Would you mind laying back so I can see where it's
sure,
hurting?
I sure will. I sure will in a minute. But right now, I just need to go get a cigarette. And this person will not let me get a cigarette. So if you let me get a cigarette, then man, address the pain. My stomach's killing me. But if I can just do this one thing.
Yeah, so you're actually not allowed to smoking here, but I can help you with that. I know you have that desire.
Yeah.
I can give you a patch that will
No. I need a cigarette. And if I can just slip right by you, and then I can get a door. Why are you doing that? Why are you doing that?
I'm just trying to help.
No. I don't want your help. I don't want your help on a cigarette, okay?
Ms. Jenkins,
Okay.
we're going to get you fixed up, okay?
Yep.
Everything's going to be just fine.
Okay. You don't know who I am. Oh my God. You don't know who I am. And if you did, I swear to God, you'd let me have, I'm going to show you who I am. I got documents in here, and I have the right last name to be here and get special treatment.
I understand.
You guys know, you all know.
I understand that. Would you mind coming here to your bed so I can, examine
Miss
it
Jagger,
and
if
try to
you-
help, please?
If you just lay down for just a second, we'll take care of you,
I'm not gonna lay
okay?
down. You need to move!
I know you're feeling bad. I know you're feeling bad. But if you sit down, you lay down on the bed, we can take care of you, okay? Here. All right.
Okay.
We'll get you fixed up,
It
okay?
hurts. I really need some help.
All right, I'm gonna get some medication.
Stop!
Whoa.
Well,
I think we better get security.
Can we get security, please?
Stop! Just stop! Oh God.
Yeah, can we have security up here in room 5?
I know I can't.
Yeah, right away.
I
Thank
know
you.
this. What happened?
Okay. There we go. I got it. Okay. So, just, I don't know, shout out or speak out. What are some things that you noticed there based on what we talked about? Or just beyond that even? They weren't listening. They blocked the doorway. Yeah, that was one of the first things I noticed is, what if they had let her go have a cigarette? She was in with nicotine withdrawal. So that would have allowed them to de-escalate her just in part by doing that. You were going to say something? Or no?
Well, just the dynamic of two men walking in like this toward a woman who's vulnerable in one of those hospital things is like, that's a bad look for a couple guys,
And both were speaking.
Not just one, right. Okay, that especially, I don't know if it was a nurse, the Caucasian gentleman, but he kept getting in her space. And it was interesting. Did you notice how there was a moment where she started to soften? She started having tears. She got on the bed. And it's in that personal space that he breached, set her off again. Like they had that moment, and they didn't recognize it, right?
And they also were reacting, but they never really used any empathy at all. And when she was approaching them, they were just continuously saying, you just lay down, you just go lay down. There was absolutely no validation of the problem she had. And then not a single empathetic stage in the meeting.
They were trying to be directive without really engaging and listening to what the patient was saying, right? This is fantastic. I'm loving all this. Yeah.
It seemed to me that the two men thought they knew better, knew more, and that she was just there for them instead of the other way around. And she wasn't part of it.
So there was no kind of, there was a hierarchy maybe that was being established, and so she maybe felt like she had to assert herself against that hierarchy.
They were controlling her because they knew what needed to be done, and she's just in the way.
Yeah, yeah.
So I think they did sort of figure out at the end that this wasn't going well, because I know you're feeling bad. So that was,
There's people online, they can hear you if you're talking to the mic.
they started realizing that they were not doing well. And one of them actually asked, or actually said, I know you're feeling bad.
That was
But it was
a
too
good
late.
thing. That was a good thing, right? How about on the chat? Do we have any that we want to?
Yes. They immediately resulted to call in security instead of listening to the patient.
They were quick to call security. And you know, security may or may not be a good call. Security is kind of a last, they took it to a last resort, but security can escalate things, unfortunately. That's when you get into, I didn't really talk about restraints, but it's I'm not sure what the guidelines are, but restraints are an absolute last resort. It increases the risk that that patient is going to be psychiatrically hospitalized. It increases the risk of injury to the patient and the people around them. So that is like the chemicals, but especially the physical restraint is your last resort if you can help it. Any more chat comments? Okay. Yeah, and then we'll take one more comment, and then we'll go to, I'll give you a few more that I saw, and then we'll go to some questions. Yeah, I'm sorry, go ahead.
Sorry, there's one more. They didn't acknowledge her cigarette request and didn't offer the possibility of getting that cigarette once she could be examined to help her. They could have sat down, changed perspective.
Okay. I am just super encouraged by what I'm hearing. Either you already all knew this or you got something out of this, so I'm grateful. We'll take one last comment here.
She gave them information that she had a past history there, and I wondered if they were re-traumatizing her because the way they were acting, like maybe they were going to grab her, try to restrain her, sedate her. You know, it just was possibly triggering other times maybe that did happen to her there or somewhere else.
Yeah, so bringing that trauma-informed perspective is fantastic. I appreciate that. I'll just show a couple that I thought of, and you already thought of a lot of these, but closed body language, not reflecting what she was saying back. And they weren't setting clear limits with her. But they were. I'll give them some positives, right? When they were told to, they gave the space. They were offering hope and optimism and some empathic statements, and they remained kind of calm and matter of fact. But we can see how these types of things can escalate if you're not. So you have the good news is you can do something. You're not a passive victim to this experience. So hopefully that's your big takeaway from today, is there's a lot you can't control, but there's a lot you can. And it's important to know what you can. Okay, questions? I guess we're doing microphone.
We want them online to be able to hear.
And while we're doing questions, I'll show some of those resources.
Thank you.
And I don't know, by the way, Sam, are the slides going to be available to people? Okay, so these, you don't have to write this down if you don't want to, but.
Okay, that was one of my 4 questions. My other 3 are comments. You said that the interface starts when the patient leaves the house to get to the appointment. And I really think it starts 3 months before that, when the patient finally admits they have a problem and they're going to go see a doctor about it. And they call on the phone to get to the doctor and they find out it's a 3-month wait. And that's when the anger begins.
Good. I appreciate that perspective. You're absolutely right, because the wait times, in
Are
my
horrific.
system, it can be a year sometimes for a specialist.
And even just getting a specialist that takes new patients has been horrific in this neighborhood. Second, I kept waiting for one of the emotions to show up as hunger. And I think both on the patient's part and on the physician's part, and maybe even more so on the physician's part, when they step out to give that patient time to collect their thoughts, they should go to the kitchen and eat a cracker, because hangry doctors are angry doctors, and there's just not enough time in
Some
the
laughs
day.
of recognition,
Yeah.
yes.
And lastly, I think it's really important in doctors' offices to keep cell phones on. And I think it dehumanizes patients when you put them in a hospital gown and take away their communication ability with their family and friends and their ability to entertain themselves. So there's that woman who, do you know who I am? She could have been a state senator. She could have been head of the emergency commission that needs to get with the governor. And they didn't give her any opportunity to say who she thought, what made her important. Who are you?
Yeah.
Why do you feel that
There's
you
such
deserve that?
dehumanizing that occurs in
Totally.
the whole system. We need to give them some of that humanity back, right?
Communication, and she's naked. They're in clothes. She's naked, and they're not giving her
Exposed.
any credence for being somebody important.
Yeah, great points. 1 or 2 last questions?
We have time for one question.
Oh, okay. One in the back of the room there.
Fresh off my massage. Yeah, so I'm a physiatrist, and I think we should speak to and often confused with psychiatry, rightly so. A traumatic brain injury, often underdiagnosed, missed, and agitation is our world, behavior, et cetera. And I just want to put in mind that we need to include that in the differential, and we need to find the history that helps to reveal that you might be dealing with that you don't know. I also want to speak to the issue of implicit bias, and that I personally witness far too often in the process of delivering and receiving care. And even as a mother doctor, just had a recent episode with my daughter who almost literally died because of bias and not being heard. And it can be quite profound, our behavior and our reaction to what the patients are trying to say. She was air hungry and had come in literally on a stroke alert out of state hospital, and had a syncopal episode during triage when they were trying to understand what we were saying about why her situation was in that moment. It had cleared a little, she was having TIAs. Cleared for that, seemed to be doing all right, but was tachypnic at a rate of 30 and was being claimed to be anxious. When in fact I got respiratory to do a peak flow, which was 70, and I knew she was getting air hungry and she was saying it. No one was listening. They were telling her to calm down, blah, blah, blah. Anyway, she had a respiratory arrest. I had to call in the respiratory therapist, who was also Black, who heard me and said she would see something was not going well. Grabbed the ambu bag and was resuscitating my own daughter. She had to call the rapid response, and then they came in. And then they paid attention. And literally, it was at that point that then they began to actually look at her and hear what was going on and see the reality of the situation. So I just want to point that out as a personal thing. And then also just recently on wards with residents, et cetera, I had a nurse get into a whole thing with me about meds, et cetera. Patient felt very unsupported. The patient was actually crying, upset because of the way I was being dealt with there as a clinician. And we have to all recognize that. And then she was able to share previous issues and, yes, the trauma of having tried to go before for care and how she was being treated. So I think this is a great talk. I think you bring up wonderful points. But I think we also have to look in the mirror and see, what do we bring when we go in the room, and how do we act? Our body language says a lot without saying anything. And it can result in a very dire outcome, which none of us wants. And I say that, my personal story, I share that because not only was it traumatizing for me, of course, and I've been through a lot of 911s, et cetera. My daughter's a long story, but it could have been preventable, and it should have been preventable. And so we hope that we all can learn to be better.
Yeah, and that's also what I'm taking away from your story is we experience traumas as well, either personally or as family members from medical systems that impact us and how we perceive things. And so it's a giant stew of what's causing it. So we need to be aware of those things, absolutely, and checking ourselves in real time. I know I'm past time, so thank you guys so much for listening.
Yeah, thank you very much, Dr. Smith. The residents and medical students you taught and then the patients you have, they're very fortunate, and thanks for sharing your wisdom with us today. That was just fabulous. We're going to take a 5 or 10 minute break. During that time, the food has been refreshed out at the bar. Those of you at home, just go get a Cheez-It, but everybody who's here, go get some more food. And also our massage therapists are here, and so please partake of that. And we're going to run right on time, okay, because you will be out of this building by 12:30 because I'm the last speaker and I'm not staying past 12:30. So everything's going to be fine. Take a short break and then we'll have Dr. Morrison when you come back.